So guys, AI, wow, they do really sink, huh? So AI, I think, is the flavor of the month on everything and anything today. And in fact, last week I saw so much happening in the space. Microsoft announced a lot of things. Google also announced. We're waiting for AWS to also announce. Yeah. And Huawei. Huawei also had an event in Nairobi last week, built around the cloud as well. So we're seeing really a lot of activity even in the local marketplace. And really, again, this question goes to all of you. You know, based on your experience, what's the single most impactful use case for AI in African health today, and why does it matter? And maybe we can start off with you, Kellington.
Good afternoon and thank you, and what a pleasure to be here. I'm seated with this team. You forgot to introduce that I have 15 years in healthcare.
Oh, okay.
Yeah. Used to be a doctor in a previous life.
Oh, okay.
But really taking the opportunity, first of all, to answer the question is, I'm sure you're wondering, what is AWS doing in a health track? Now, at AWS, we actually do have a fully fledged medical practice, which is actually kitted out with doctors and medical practitioners. And our mission actually aligns in terms of how do we leverage AI to enhancing access to healthcare, improving outcomes, reducing cost, and unlocking value based out of the data. And that's where our extensive and capabilities from a cloud technologies provider actually stem from. Now, to your question with regards to what like AI innovation that I've seen. So we have one of our partners called Huron AI out of Rwanda. And one of the gentlemen there and the founder actually had a case whereby one of his kin had cancer and they could actually not be able to get medical care in good time. And the statistics he shared with us is that at the time, this was in 2003, outside of a population of 3.5 million people, they only had about 15 oncologists. So you can try to figure out what that ratio is. So what he then did is actually came up with an AI-based platform that enables caregivers to actually interact with their patients remotely, be able to follow up with them, get whatever anecdotes, how is the medication going, so that they can continuously monitor and give care to them. And I think that for me is quite something that's impactful because it goes to extend and give access to healthcare.
Great. I'd like to come to you, Dr. Joyce. What are your thoughts around, what are the things that, the single most impactful use case for AI within an African healthcare today?
Yeah, so thank you, Moses. And as Kellington said, I'm really excited to be part of this panel and also happy to see that we have very keen participants and a very keen audience. I'm planning to have a lot of fun in this particular panel, so I'll be saying some things that will be hitting all of us below the belt, but let's enjoy. So I decided to talk about Kenya. The impactful AI examples I can quickly think about are within the public health programs. So we have TB, tuberculosis. So there's TB case finding, and we've seen computer-aided diagnosis of chest X-rays being done in Siaya County. But we also have something that started a few years back in the HIV program, where after some time, okay, for us, Moses, I don't know that you're my age, but when we were young, you could be tested for HIV even without knowing. Then at some point, came in the legal issues, so you have to seek consent, and then we test you for HIV. Then at some point, the donors said, we don't have enough money to keep on helping the country to buy HIV test kits. So now we needed to define who is this we are going to use the test kit on, and it better turn positive so that it's not it's not a waste. So came in a screening tool based on the lots of data that we had in the HIV program, and we call that the HIV screening tool to determine two things. Are you at risk and therefore need to be put PrEP or to be put on pre-exposure prophylaxis, or you have been tested and then you turn positive, so therefore you are put on antiretroviral therapy. So we have that, and it's been in use now for about 2-3 years, and we are still looking at its results, improving it by the day, because now you know what Trump did, and so even the test kits have become even fewer. Yeah, so thank you. I'll stop at that.
Okay, great. I'd also like to hear from one CIO of the year. What's your perspective on this?
You can hear me? Oh, good. The easiest way, I think, to use AI in healthcare, and especially in Africa, is looking at possibilities where you don't need a lot of groundwork. As Daktari has, as we're having the discussion with Daktari, is that we need a lot of data to actually get AI to work for us better. So in my organizations, we implemented AI, particularly computer vision. So this is to manage ICU patients. So what happens is the system ensures that the patient's monitoring is ongoing. So what this does is it helps the nurse transcribe what's going on with the patient, because the nurse always has to be at the bedside of an ICU patient recording what's going on. So now this work is being offloaded to the computer vision. Using AI is able to transcribe everything that's going on with the patient monitor, with the patient themselves. And this capability now helps our nurses to have more focus on the patient and do more patient engagement activities instead of documenting. The other benefit we have realized from this is handover used to take about 1 whole hour, because you're really explaining to the person you're handing over what has been going on with this patient in the last 12 hours. So it became a very daunting task, but now handover is like 15 minutes, because technically the person who has been with the patient is the AI system, and the person coming on board just needs to know what are the next procedures need to be carried out. So with this system, we're able to now get more data in correctly. We're now able to analyze more activities, because now it's computer vision. We're now checking, is the patient being turned at the appropriate frequency? We're able to keep track of what's really going on with the patient. If there's an emergency that the nurse needs to take care of and has to leave the patient for a while, the patient is still being taken care of by the system, and it's able to raise alarms when needed, if so needed. So I think this is the best place to start, whereby the data collection part is already automated, and now you're doing actionable events and really helping the workforce to be more focused on the patient, to be more focused on outcomes.
Fantastic. I mean, I really love the way you sort of talked about the different scenarios in which AI is, helping you within the organization. And I think it's incredible to see that it's so many benefits, so many cost savings, time savings that come through that process. I'd love to hear from you, Adam, just your point of view in terms of the single most or some of the key use cases that you see and why they actually matter.
Hello? Okay, now it's on. Okay, thank you. So I don't want to say what others have said already, but maybe I can add a few areas that I think have been most impactful that we've seen. Some of the most impactful are maybe the simplest and maybe least exciting. But even when I first came to Kenya in 2015, the first project we were doing with the electronic medical record system had such tremendous impact in 2 areas. One, on the fraud reduction issue in terms of revenue management, and also medicine, what's the right word, disappearance, or consumables and other things like that. And that, I think, is really interesting. I won't maybe go beyond the fact it's very interesting, but I think it's very impactful and very interesting. Once it's digitized, digitization has challenges. The training issues, the user turnover issues, people pulling out power cables and Ethernet cables and sabotage and things. Then the second aspect I think was really interesting was around the stock management and ordering system, mostly for medications, but not only medications. Because I think that's the really difficult bit to get right, but really, really critical. And it's not very advanced AI, right? To basically understand your past trends, about what medicines you might need at what times of the year, for what kind of patients over historical periods, plus bring in some new, more timely based information, depending on the season and other emerging diseases that are happening and so on. and to then have that stock and medication ready. And of course, at the same time, not be having expiring stock. So I think those are the least sexy of aspects, but I think that the two most impactful. And AI, of course, is a part of it. It's not, the more AI you have, the better those two areas can be in terms of detection of issues, in terms of planning of stockouts and so on. The more modern, I guess, and more sexy, most impactful thing, I think, is probably the one that requires least engagement with users, in the sense of it's very quick and easy to implement, which is just the guided diagnosis of images like X-rays and other things like that, and CAT scans and things using AI software. You don't have to spend weeks, months, or years training and installing lots of complicated hardware and working with lots and lots of users, where you just take the images and then you send them into the cloud in a sense, and then you get kind of feedback, and then you can either agree with that feedback, accept that feedback, or disagree with it or so on, depending on the specialist who's working on that system. But that, I think, is really impressive. And it can really help reduce, misdiagnoses or catch things that aren't caught otherwise, and as well as speeding up areas as well. So I'll just touch on those three topics, if that's okay.
Great. Thanks so much, Adam. Kellington, I'd like to come back to you. AI requires massive and secure compute infrastructure. How is AWS enabling African governments and startups to build health innovations at scale?
Thanks, Moses. So coming from a point of view, I believe for those who've interacted with AWS, we do provide the most comprehensive set of cloud capabilities, and we've been leading from a Gartner perspective. So that alone sets up a lot of either governments or startups that work with us to be at par with organizations that are highly even larger than them. So cloud capability, first of all, came to actually standardize or level the playing field, such that, for example, if you're trying to develop something in Kenya and you're competing with Pfizer, you basically have access to the same technology. So it's not really a question around technology at this point. So what do we go further and do? We normally make available our culture of innovation, which is what we call working backwards, available to either governments that we work with or our customers that we collaborate with them on, rather. And our culture of innovations, what we do, and I was sharing with the team earlier on, is that for a tech company, when we kick off our engagements, technology is the last thing we talk about. We first of all want to understand, what are you thinking about from an innovation perspective? If it's AI, what is that durable need? And the key take I want for people to take is always innovate or build around a durable need, right? Because that essentially will enable whatever it is that you build to withstand the test of time. So our working backward session basically typically takes about a couple of iterations of about 3-4 days, steps of an engagement, whereby we go through understanding what are the challenges, who's going to be, like, for example, your target audience, who are going to be the various inputs you're going to be putting into your particular process. And at the end of that, we normally want to come up with something called a PR FAQ. And if you've read about the AWS or Amazon culture of innovation, you might have heard those words, PR and FAQs. So the PR statement basically is what would be the newspaper statement for when you actually launch that innovation and or product? Because what would you be communicating? Because again, if you're going to be talking about it is AI this, it's going to be a virtual machine there, then you're really not innovated or build a product for who your end customer was meant to be. And then the next thing that we produce against that is what we call now the FAQs. What would someone using that particular capability using that particular solution be asking themselves? How does it work? They'll never ask you how much memory or how much RAM or which model did you use. It's really around what the usability of that particular product is. So that's one of the capabilities that we transfer to either governments or startups that we work with from our DNA to help them build, because we've seen when we use that particular capability, the types of products that can actually be built. And one of them was actually AWS as a product, because for those who know our history, AWS came from Amazon.com, which used to be a bookstore, right? Now think about everything that we've innovated from then to Prime. Now we are in low Earth orbit satellite space with our Project Kuiper. Everything we do takes that journey of innovation, and that's the DNA and thinking that we normally like to transfer to our customers and partners, because we know the technology will work, and it's not about tech at that point.
Thank you so much for that, Kellington. Dr. Joyce, I'd like to come back to you. And my question to you is, what role is the Digital Health Agency playing in embedding AI in Kenya's national healthcare systems, and what foundational gaps are you prioritizing in that process?
Yeah, so our chair really described the Digital Health Agency as the home for digital health transformation. And one of the things that we are doing is using technology to transform how we collect our health data, how we collate it, and how we analyze it, all the way to getting insights from it. So foundationally, so first of all, I'll say something that I said to the gentleman while we were preparing for this panel. I was like, I don't understand what's the hula baloo about AI. You know, we keep talking about AI, people approaching and saying, Joyce, when are you regulating AI? AI has to be regulated. And you're like, what are you talking about? Because for AI to happen, there's lots of stuff that has to happen. So we've been collecting data. Yes, we've had a lot of health data since the 70s, 80s. Doctors have always written their notes. Clinicians have always done their notes. Nurses have also done their notes, but it's been in a manual format. To now have data that can make sense for you to be able to look at trends and patterns, you need to put it in a format that is accessible and is easy to look at. So in comes the digitization component. So we have to digitalize our health facilities, move them from manual to fully digital, end to end. It is not a one-day job. It is something that must be done, must be planned for, and we are happy as DHA. That's one of the things that we are doing. The other thing is when it comes to the Social Health Authority information, yes, there's also been a lot of data, but that data was being collected in various forms, and who was looking at that data? So we also have to build capacity for people to look at that data in a manner that enables them to identify those patterns and trends and build back and see when we tweak this place and tweak this place, are we able to identify that this particular patient who we are managing for diabetes will actually fall out of care and therefore needs support way earlier than right at the start when they are starting their care. So we plan for their support to support them a bit more than the next patient who we can already tell this one probably will be in care, will take their medications well. So we need a lot of capacity building. Do we have that in the country? The third thing is understanding of the health sector. Yes, we can be collecting lots of data, but if you don't understand health and you are thinking because you understand how to do p-values and use SPSS that you can then be able to gain insights, then that's also another problem. So we are, as DHA, we are pushing for a lot of capacity building, a lot of technical assistance in getting our people to be able to analyze their data at whatever levels, whether it's at the community level, at the health facility level, or at the national level, analyze their data, identify these trends. Then one other thing is when we are doing, so that's the foundation. You asked about the foundation. So digitizing and moving us from aggregate level to individual level data, from manual to digital data, and then ensuring that we are incorporating various principles. For example, we know that garbage in, garbage out. That data being collected, we have to invest in it being of quality data. So we are working with county governments, working with our various partners to ensure that whatever data we are collecting is quality data. Then you cannot be talking about AI when you are working alone. AI is collaborative, or whatever you want to call it, analysis and insights. It's collaborative work. It's not something you do alone in a room and decide you have an AI tool to identify who needs to be seen by a clinician and who needs to be seen by a nurse. No, it's collaborative. And then there has to be transparency. When that model finally shows up, you have to be able to demonstrate, this is the data that I used to get to this model. So do we have that team in the country that is going to be looking at those models from a very objective way and determining that this model is ethical, this model is inclusive, doesn't leave out the Mandera person or doesn't leave out the urban person, it's inclusive. And then this model has used the right data, that's quality, for then Therefore, this particular AI model can be taken to scale. So we are building those structures with the Ministry of Health, building that team that then one day will grow up to be that team where you take your AI model and it's looked at objectively, and then we determine that this is going to scale. So that's what we are doing foundationally as we look forward to now going to AI at scale in all aspects of the health sector. There'll come a time when the data we are collecting for SHA, like for means testing, we will be able to identify that you, when we have been looking at your data for the last 5 years, you, ukipatiwa, you pay premium for 1 year, you are really having difficulty. So you should pay every 6 months. But we need that data to be able to look at it. Right now, the law says every year. But there are people like Moses, when you look at them, you can pay premiums for 5 years. And AI will help us to identify that. So those are the levels, but we need to, of course, build that foundation first. Thank you.
I don't know why you cited me there. I don't know what made you think I can pay for 5 years. Yeah, I'm not Nigerian, by the way. I just like to dress this way. But I think you really put it beautifully. You sort of tied it up nicely in a bow in terms of we need to get the basic pieces in place first before even we talk about AI. And as you said, garbage in, garbage out. If the data itself is not accurate or it's biased, then your AI is compromised from day one, isn't it? Yeah. So wonderfully described as you put it there. Geoffrey, you've given us a wonderful story about how using AI, you're reducing timelines. But what is the resistance? What are the challenges you faced internally? I can't imagine it was a smooth road. And whether it's clinicians, patients, nurses, administrators, when you're integrating AI into your hospital systems and processes, what's that been like? Can you tell us a bit more about that?
When it comes to basically bringing change in an organization, I usually have a following or I follow a particular principle. I usually say you have to identify the problems that are there and understand 2 things about every problem. The problems people suffer from, the problems people enjoy, right? So most likely the problems that people will come to their management, the IT department, they'll usually come to complain about problems they suffer from. They'll never come to complain about problems they enjoy. So you can imagine, I've just given you a scenario of how we are saving time. Now you're bringing an AI system whereby you're telling them we are actually going to reduce the amount of time you're in the hospital. So you can imagine no OT, talking about adding about a couple of locum hours and all these things. So they're seeing this disappearing. So it's a problem they will definitely enjoy because that's more money in their pocket. But what's the give back that you're giving them? So if anything you'll ever find about especially nurses is that they really love their patients. Sometimes more than their money, but they really love their patients. They really go an extra mile for their patients. So you sell them the patient care, the quality of care that they're about to deliver to another human being. So in terms of resistance to my implementation, we had it a bit because they were unsure about what the eventual outcomes will be for them and the patient. But once you start showing them that actually you get more time, right, and you actually get better outcomes, they start getting the buy-in. So by being able to understand what their fears are, what their selfish needs are, you're able to navigate some of this resistance and able to deliver for them a solution that agreeably is a good solution and a good middle ground. Because you might also bring in a full AI system that even does their job. There's a robot that comes and takes care of the patient. You tell them you don't need them anymore. I'm sure by the time I'll be done with that proposal to them, I'll be out of the door before I can finish my proposal. But you always have to find that middle ground whereby you allow for the professions to work and the technology to actually accelerate their work.
Fantastic. Thanks so much for that. And Adam, maybe to sort of as a segue from his responses, what's the single biggest barrier preventing AI tools in health from moving from the pilot phase all the way to nationwide deployment, and how can we overcome it?
Okay, thank you. I think Dr. Joyce already covered some of these key issues.
Yes.
But certainly the digitization of the facilities themselves is, I think, a very difficult challenge. As I mentioned earlier, some of the issues around users, which is staff in facilities, which can be all the way from the cleaners, I say, that start pulling out cables by mistake or intentionally, all the way up to, of course, the clinical officers and the medical officers and the administration, which are maybe even more critical, pharmacists and so on. Huawei is very much in the infrastructure space. And we've also experienced that doing things, how do you get the balance? That's, I think, the key challenge. As much as having good data is very important, I think you have to have accurate data, and sometimes you don't get perfect data. So one of the challenges we found is that in the attempt to use WHO standards or other standards, you require such huge amount of data and detail that the users, in this case the clinicians, don't want to follow those standards or take shortcuts because they spend too much time filling in forms. And this is not a problem unique to Kenya, but anyway, everywhere you go in the world, and maybe in the more developed countries it's way worse, you get endless complaints that people spend all their time filling in forms. By that they mean digital things. And no time actually with patients. All they're doing is filling in stuff. Now AI could help smooth that out. Some stuff could be automated and digitized, but it's still a big challenge. So if you end up requiring people to spend too much time filling in things in order to get the world's best data set ever, they won't fill it out. They'll find excuses, or they won't be able to get through enough patients because they'll spend 2/3 of their time filling in forms and only 1/3 with patients. Your number of patients per doctor is going to go down dramatically. So that balance is very important and very difficult, right? People talk about health, you think it's black or white, but somehow working out a balance. I'm not a doctor, so I don't want to say from an ethical perspective what's correct or not, but from a realistic perspective, it's really challenging. Same with infrastructure. Ideally, you wouldn't have to invest in really expensive, complicated infrastructure, but if you have even 10 seconds of downtime with your computer or your access to the cloud, doctors have given up. They're not waiting. Things hang, they're done. They've gone to a piece of paper, written 3 words, and so the next patient come in. So it's really difficult. If your networking is not good, your internet's not stable, you haven't got power backup, it all requires things. We're in the networking and infrastructure and power ecosystem, and that they're really challenging. And no one wants to spend a complete fortune on having all this amazing high-end infrastructure. But if you don't, you have to work up a fail-safe and another fail-safe and so on. We had all these problems before, and we've had some CSR projects, because I deal with some CSR programs, and they did fail because we did not spend enough money in donating the best equipment, having the best maintenance, having the best support, the best service, retraining people every week and every month. It was just too expensive from a CSR perspective, and it didn't work. Administrators left, were moving to other facilities, staff were retraining, equipment needs to be maintained. We even had a case where we put in equipment and the hospital built a new wing. They didn't move the equipment to the new wing. They just stopped using it. It was really bizarre. No one even asked us. We could have moved it for them. So they just reverted back to paper in the new wing because the equipment was left in the old wing. So that was really, really strange. Sorry, I get distracted, but it's I find it's very interesting. So that was one, definitely about the infrastructure. And power is obviously critical. Health facilities in Kenya have always known power is important because of refrigeration, but it's also critical for digital tools and software and UPSs. And power, even batteries don't last forever. You need to be maintained or replaced after a certain period of time. Even solar panels have to be cleaned and things too. And the second thing then, I think, on the software space, moving now from hardware to software, because also in software, because of Huawei Cloud, the key challenge we faced with the EMR was often customization to meet the facility's needs. Sometimes it's very simple. Who is the user? What rights should they have? What is their password? That kind of stuff. Some is how many points of care do you have? Do you have a pharmacy? Do you have the radiology department and so on? You have to customize it a little bit. The more you customize it, the easier it will be to use. So hopefully the more likely it will be used. But often you want to give either the simplest solution or the most complex solution, and you have to really try and customize it. That takes time. Not necessarily money, but time. And time, of course, is also money. And we found that's also a real challenge. Then you have to localize it as well to the specific needs of the facility. That can also change over time, as I mentioned. Facilities can grow and expand, and people can change. They have to keep being updated. Public sector is also very, very hard. They may not have people in the facility with the expertise. You have to call on the county or the sub-county and so on all the time, which is not so easy. Then the last thing I want to mention is the issue about data and data localization. Of course, it's really, really sensitive and critical, the health data, in terms of keeping it secure. Sometimes more secure can be on the cloud. Sometimes more secure can be local. Sometimes it can be hybrid, depending, and sometimes you need backup. So, local data you think is secure, but it's not if somebody's pouring water on the server by mistake or it's kept out in the rain. Sometimes it can be in the cloud, but if that internet connection is not stable, then you can't get that data back from the cloud either. So it does require some careful thinking and planning. I think hybrid solutions are normally going to be best. Of course, it also data sovereignty issues, and of course, cybersecurity issues too. And that user rights and user access and user protection is critical. It comes back to, I talk all the time, at Huawei, we have all our staff phones have to have an app, and everything that goes to work is in that app. That app is like a closed environment. You can't take screenshots of that stuff. Anytime you forward or send anything is monitored by the company. I would not want to ask Dr. Joyce, if she knows or doesn't know, how many of the health workers in this country, public or private sector, are probably using personal email accounts or accessing email through their phone, where they could be screenshotting data or sharing data or PCCing people or putting on USB disks. Our laptops also have encryption. You can't copy stuff off. Put whatever viruses you want on our computers. We don't mind. We think we can scan them and deal with it. You cannot take anything off our Huawei laptops, like our work laptops. Not Huawei laptops. You can buy your own Huawei laptop, do whatever you want with it. But our work Huawei laptops. So that's also really, really critical. And we have to also be very careful. Of course, health data, maybe like financial data, are the two maybe most important sources of data that are hugely at risk, and how they're used or misused. So I think we have to be really careful about the cybersecurity and digital sovereignty, localization of data, and how to manage that. Again, not aiming for the perfect situation, because we'll never get there, but to keep the risk as low as possible and have that balance of local hardware, cloud hardware, and software, and so on. Maybe I'll stop there. It's probably enough for now. Thank you.
Thanks, Adam. I think you really sort of talked about so many of the caveats, things that you've seen from practical experience as opposed to hypothetical, stuff like, people didn't move a server or a piece of equipment because they went to the new wing and never bothered to let you know that it needed to move. So, there are basics here that we need to sort out. So now I'd like to turn it back to our audience and the people who are in this panel. Please, gentlemen at the front there with your hand, maybe we can get a microphone to you, and then we'll come to you here on the left. Is there a microphone available? Do I need to? Okay, okay. Maybe you can introduce yourself, your name, and which organization you're from.
Okay, fine, thank you. Dr. Jeremiah Mumo, Digital Health Agency from Kenya. Thank you, panelists, for the good presentation about the AI. And really, that's good insight to it. Yeah, surely. I want to send on the big data, because that's another aspect of AI, and a lot of things have been done through different data visualization tools to that. I want to send my question to Geoffrey about diagnostic part of the AI. We are introducing many diagnostic tools which are using AIs. Remember, the operation of yesterday, it was open. Today we are using AIs to do even from brain surgeries to heart to everything we are doing. You also realize that we have a lot of diagnostic kind of tools using, especially in reproductive health, whereby even ultrasounds, a nurse at low-end facility can use that. How prepared have you prepared your staffs to this? That is my first question. And are we ready? Do we have a way of making sure that as we move to AI, issues to do with privacy, stigma, especially when to our healthcare, our clients whom we see on a day-to-day basis, are we assuring that the information we have is safe? To our team, Kituku and Adam, normally even in my own normal phone, we always cared of somebody having a second here when you're having conversations. When we are bringing these higher equipments, are you sure that as this data, and we have seen it even, whereby you come up with a good machine in a facility, but the moment you are scanning, the data is going to America direct from the manufacturers of that system. To me, it will be more worse, even when we apply these diagnostic equipment to the high. How safe are we on our data, both on transit and on rest? How safe are we as we approach that environment? Lastly, to my own boss, Dr. Joyce, in Kenya, we don't have a policy. Do we have really a clear policy to talk about when we venture to this area of AI? What do we need to do, at least to assure our Kenyans? Kenyans are always assured when we go, and that's why the Constitution 2010 introduced public participation, and I know very well, because you are a policy guru and research, you know the process on involving anyone. How far are we to make sure that we entrench our AI, especially in health? AI, I know it's applicable in issues to do with supply chain, in agriculture. However, a lot of AI is now being invented in health. How do we protect our own citizens' health as they seek healthcare in these processes? Thank you very much.
I think those are 4 questions, huh?
Yes.
Yeah, so I can't remember each and every one of them, but I think we'll start off with Geoffrey, and then we'll take it from there.
You can correct me if I'm wrong, but the first one was, I just interpreted it as user adoption, how prepared we are for AI. Number one, everybody is waiting for AI to come into their workspace, irregardless. Even from the cleaners, they're waiting for something to happen in terms of AI. And we have even seen CEOs being told they're going to be replaced by AI. So I think as a country, everybody is somewhere in the back of their mind, they're like, something is going to happen around my professional life, and AI is going to be involved. So I can say that gives us a bit of an easy time in terms of trying to introduce AI, especially in the work life. But the other thing is, how are we prepared for the impact as ourselves? There's just a recent article about an organization that fired almost 700 of their staff, had to rehire them back, because AI does not work alone. It actually works with people. Yeah. Now, that being said, it's people using AI that are going to be very, very happy with AI coming to their workspace. So a lot of awareness, a lot of training, and we also have to be aware of how AI tools are going to come into our workplace. The best example I usually have is a couple of researchers were training a robot how to hammer in a nail. So they gave the robot a hammer, showed it the nail. So the robot forwent the hammer and just picked up the nail and hit it straight into the wood. And guys were like, no, that was not what we trained you. But the robot understood, had AI. The robot understood, I'm made of metal, same element that the hammer is made of. So our tools are going to change drastically, because AI understands context, it understands what the objective is and how it's going to be used. So we need to prepare ourselves. We need to be aware and alert about some of these things that might happen in our own workspace. And so this is just the best time. If we don't use AI maybe once a day, it's better start practicing using AI almost every day. Just go in there, use ChatGPT, ask it stupid questions, and just engage with it and start getting the gist of it. It happened during the computer revolution. People just, how many of us know of you went to an office and the only thing the person at the front desk was doing is playing solitaire, right? But very soon, that person was now crashing Excel sheets, has a whole system to manage guests going in and out, is doing analytics and reports on how best to manage guests coming in and out, right? So you need to start from somewhere. And in my advice, start with the simplest thing you do every day. Find out what that is, see how AI can help you. And you'll just start getting a hang of it and start getting a gist of it. And I think as we continue getting a hang of it, the technology will come. And when it comes, you'll be ready. And you'll not be amongst the people who will be worried. So to me, that's the easiest way I can say we can really drive user adoption. But I think in Kenya, we are really good on that. The next one is on privacy. How do we make sure that our models or our data is not being shipped outside? Now, this goes to really how you deploy your AI. So if you're going to deploy your own AI, you need to design it in that particular way. You might need a lot of consultations from maybe the AWS team or the Huawei team on how to do it. But here's a scary story. So, of course, like I'm telling you, go use AI today. So somebody else went and gave the same advice. Go use AI. So people went and used AI. But guess what they were putting into that AI, which is public? They were putting in private confidential data that belong to the company. So they are saying, I have a product X, which we are thinking will work with the particular customer base. Yeah. So what do you think about it? Give me an analysis. So basically, AI doesn't know everything, but sometimes you'll feed it something that will make it connect two dots together, and it lands. So a competitor was sitting on the other side going like, I have a product, who do I sell it to? Let me go ask AI. Do you know what AI did? Told it exactly who to go and sell it to. Because, and then, so yes, if you're going to deploy AI with very sensitive information, very critical information for your organization, talk to your IT team and figure out how you're going to do the privacy around your AI such that that data is not moving outside your data privacy. Okay? So I think that was last question to me. You good?
Yeah.
All right. Thank you.
So I think I know Dr. Joyce will respond to one, but Carlington, I think there's something for you around the data sovereignty question as well.
Thanks for that. So I think the questions that were raised were pertaining to data sovereignty. There was an element of data localization, and the all too favorite around data security. Yeah? So it's very interesting. So right now we are connected, a lot of tech people around, smartwatches, I've seen quite a number, and all of us are busy freely giving out our data around how many steps we've done, number of what our heart rate is, how we slept last night, and no one is asking about the data security or anything around that. But when it comes to institutional conversation whereby you're thinking about a data strategy, all of a sudden, is our data going to be safe? Yet it's for the same citizens that you're actually trying to protect. So I normally find it very interesting, similar to what was shared earlier on, whereby government says we do not use cloud, but then everyone is on Gmail, right? Very, very interesting, and no one is concerned. Or similarly, everyone actually, where we actually share critical government information, it's on WhatsApp. Right, or from the cabinet secretary's office to a memo that's supposed to come to Carlington, it's printed on a document said top secret. But this person is going, and as they're getting there, they're taking a picture, and it's on WhatsApp before it actually hits social media, before it actually gets to the intended person. What I'm trying to get at is that security for us at AWS is job zero. And you need to think about security outside of the tools that you actually use, because AWS will be a tool in this instance, right? Same as Huawei will actually be a tool or technology that you're using. But does your security strategy actually transcend whatever technology platform that you're working with? That's question number one, and should be job zero for any organization. When it comes to security and the interaction with us, we normally look at security as a shared responsibility. So AWS will be responsible for security off the cloud, right? And what makes up the cloud? So the infrastructure, the physical spaces, the machines, the servers, and all of that. But then as a customer, you're responsible for security in the cloud. So it's very important. I might give you the best technology, same as Huawei, but if you go and put your password as your birthday, right? We can talk about security for here to Timbuktu, right? So you're responsible for ensuring that you secure your data, encrypt it, all the best practices. That's what I'm saying. It's important to have a clear security strategy for your organization. The technology works. To just demonstrate the same, you'll see, like, for example, we have accreditation from HIPAA, ISO 27001, 2015. We have all of these. You know, like there you say, someone has more degrees than a thermometer. That's the level of certification we have. But how does that protect you if you don't have a similar security conscious organization on your end? You're basically leaving the front door open for any bad actors. Now, the other interesting thing around data sovereignty and localization. I think this panel shouldn't have been around AI. It should actually be about the importance of data, really, because data is what is going to enable AI. Now, you would assume that business strategy and data strategy go hand in hand, but they don't. A lot of organizations and people will talk about, is my data secure, where is my data, but they really don't know even what data they have. Most organizations, and I do not want to do it by a show of hands, is there's something we talk about called a data catalog. How many organizations today actually put in place a data catalog, knowing this is the set of information we have, this is the owner of that data, and this is how we've actually gone further and classified that data to say this is how we treat that data. As an example, information around your supply chain system of how you buy tea, toilet paper, those sundries for the office, against patient information, would you treat that data in the same way? Probably, I think not. You're going to apply different policies. So what I'm saying to that in terms of issues around data localization and data sovereignty, first of all, understand the data that you have, classify it, and then define how do you treat those particular types of data. As Adam said, the best of both worlds is what we call a hybrid strategy. And then to cap it off, I'll say there are certain capabilities that we need to, that will be real to us that we might not necessarily be able to get them in country at all the time. So for example, NVIDIA, I don't know if they're here, are touted to be the best when it comes to their GPUs, right? What are the chances of us having that type of capability in country? So at some point you will need to leverage capabilities that are outside the country. But what's going to govern how you use those capabilities is really going to be what you put down in your data strategy. I hope that captures your question.
I'd like to come back to Dr. Joyce. I know that your colleague here asked a question specifically to you.
Yeah, I guess he wanted you guys to know that we do have a health data governance framework. So it's somewhere around being endorsed as one of the key regulations that the Digital Health Agency is working on. And in this, we've defined actually, right from the Digital Health Act, what types of health data are in the health sector. And then the governance framework goes ahead to say what should be done, when, for what type of data. But we also have a section that talks about if you're going to do AI, then you need to ensure that you meet certain principles, and I've already mentioned them, the transparency bit, the ethical bit. So what we are now doing is working with the Ministry of Health, the directorate that deals with digital health and policy, to ensure that we set in mechanisms that can then implement what I talked about earlier. So who determines that this model is ready for scale? So we need that mechanism somehow. All this we are doing because at the moment we feel and think that regulating AI in healthcare will stifle innovation. We don't want to rush too fast to regulate, because when we regulate, then everyone is, walking on eggshells and doesn't want to try something and that could be of help in the health sector. So there will come a time when there will be a regulation, but for now, the data governance framework plus the mechanisms that we are going to work on with the Ministry of Health are enough, even as we get to understand this particular field. It's very easy to talk about AI until you go and meet that doctor who everything you say, they just type somewhere, then they say, you seem to be very pregnant. And that time they're talking to a man. And the doctor doesn't want to move from there. The man is being told, but you are very pregnant, sir. I can see the symptoms you've given me. This is pregnancy. And you are there seated and saying, but I am a man. Or is that the kind of doctor you want? Or you want a doctor who is using AI to kind of like complement what they're doing, but they have not left their brain at home. So you can ask your partner, the next person next to you, which kind of doctor do you want? The one who insists that you're pregnant and that time you're a man because the system has said it. You must be pregnant. Or the one who has their thinking cap on and using AI to complement some of the processes that they do so that they can have more time to take care of you. So you can just ask around there and ask, which daktari do you want? And you'll then know where we are at with AI. A lot of times when people talk about AI, they think it's coming to replace the human being. But AI cannot be done without the human being. And I think Geoffrey talked about it. So it's how you look at it. It's supposed to be a complementer, an enhancer, but not necessarily a replacer. Yeah, thank you.
Thank you for that. I don't know, Adam, if you had anything to add to respond to that. There was this gentleman at the front. Please, if maybe we can have you as the last question. I don't know that we have enough time, MC. We're out of time. Okay.
So thank you very much. I just want to thank first the panelists for that very enriching discussions. Before I ask my question, I just want to give you a background. Some years back, many years back, I was posted as a medical officer to a very remote place in northern Kenya. And immediately I was posted, there was an outbreak of a Rift Valley fever. This is a very, it's a hemorrhagic disease, which is very infectious. So what happened was that I only had a stethoscope. There was no laboratory, there was nothing. But then luckily I got a university, Texas University in America. So they came in, they installed a satellite, and then they brought me some gadgets. So in the morning I will do a ward rounds, and then I will listen, auscultate the patients, and then they can listen from the other side. They can also observe, and then they give me the diagnosis. And then they brought me another machine, which I could just do quick test. And then from there, we could manage the patients together. So I wanted to ask you, what is the role of AI in telemedicine? I think that's something that did not come out very well, and that's something I think a question I want to get. I'm Dr. Mohammed Sheikh. I'm the Director General for the National Council for Population and Development. We worked very closely with Dr. Joyce Omishi. She used to be my boss, and we introduced what we call HIV testing and dual testing in the Ministry of Health. So thank you very much.
Right, thank you for your question.
Okay, well, I'm a big fan of telemedicine. I was doing that 2015 project was in Lamu County. I've done other work in Isiolo and Kakamega. It's really interesting. I think one of the biggest challenges in the public sector is the system-wide incentives and misalignment challenge, because the busiest hospitals are the ones with the experts. So how do you get the busiest hospitals with the experts to allocate even more of their time to support the ones in remote areas? And we often found the ones in remote areas, they're not that busy most of the time. I was in Garbatula, there's a few patients every now and then. And it's not a criticism whatsoever. I guess it's good they're not busy, but that's the reason you can't afford to put very expensive, highly qualified specialists in a place that doesn't need them more than once or twice a week or once or twice a month. Hence, you have the referral system, right, from the 3s to the 4s to the 5s and 6s. But the 5s and 6s are really, really busy and really crowded. So it's a system-wide issue that has to be resolved. I don't have an answer, but it's a challenge that I wanted to mention. But I wanted to also bring up, and I liked your example of what you were doing before. We saw it, very small seeds in Kenya during COVID, where some private facilities would give you some medical devices, or people would just go and buy them, maybe illegally, maybe legally, right? Blood oxygen monitors and so on, and go home and be paranoid and crazy about their SO2 levels. But now, and I'm British, so maybe I know a little bit at the UK, not a lot. There's a very intentional strategy the UK, of course, is a very public sector dominated healthcare system. The private system is very minimal, although more public sectors paying private sectors to take over public sector. But anyway, a very intentional strategy called hospital at home. They don't have enough beds. Beds are very expensive in hospitals. So they're giving you medical devices and saying, take them home. You sit at home. We get updates frequently, minute by minute, hour by hour, depending on the device. A nurse may come every 3 hours, every day, every 2 days, depending on the illness, to check up on you. But they realize once you're beyond critical, you don't need to sit in a hospital anymore. You just need to recover, you need some monitoring. And they're actually really rolling out at massive scale now. So the government will give you some medical devices. Some can be simple, like the watches. Some can be a bit more advanced. And say, go home, someone will be following up with you and checking on you, and you'll come back, and eventually at some point we'll take those devices back, you'll be cured. And it's become a very, very big priority in the UK healthcare system to save time, save money, and patients will recover much quicker when they're home. They've got family members, there's a friendly environment, you know, there's this whole aspect, I'm sure you know about the social determinants of health, where you recover much better depending on your social environment, not in a hospital where you could get more infections, you're permanently stressed, and so on. So that's really interesting. I've not heard any conversation yet in Kenya about that approach, but it's something that's also worth looking at. The other good thing about the UK system, the NHS, they do a lot of research around it. Their data is relatively shareable with other systems around the world. And they have a very good economic analysis about whether things make money or don't make money and so on. And they often do share that with others as well. So it's worth looking into that space and thinking about that. Because I think that's the trend, right? Whether you voluntarily share your normal watch data or whatever, or you want to, so I'm out of time, I know, get very customized specific medical devices. But AI is really critical in that. Now these devices can do incredible large amount. Huawei even has a watch that's a medically certified device. I don't think yet in Kenya, but in Europe and in Asia, that does your blood pressure. You know, it's like the one on your wrist, on your arm, but it blows up the air in your watch a little bit, and then it lets out again. And it's medically certified and has passed all the tests to give you the results. You have to keep your arm very still for it to work. And if it doesn't work, it'll tell you it's not worked. But this is very simple, right? Now there's so many things with just simple cameras that can detect many issues with the eyes. Many microphones can detect way better issues with hearing than many other more expensive devices, just using AI around that space. So I think this will be the trend. The question is having a regime to certify these things, and ideally only allow those that have passed the medical tests to be used by consumers. Again, the UK and the US and others have got these regimes in place. They certify software and they certify hardware as being medically equivalent devices. I think this will be the next step. I know they've got a lot on their plate, probably the DHA, but I hope at some point they'll also get to that point about medically certifying software and hardware, that consumers and facilities can start to use that stuff that will really democratize and also localize production of both software and hardware for experts here to be creating rather than always buying all this equipment from overseas, which I think a lot of it unfortunately is done. A very long answer, but I hope it's interesting. Thank you.
Great. So it seems like we've come to the end of our conversation. Unfortunately, we can't take any more questions because we're a bit behind schedule here today. But I think what I'm taking away from this is that we're definitely not completely behind. AI is real in Kenya and in Africa. We do have systems in place. We do have elements of regulation coming into play. And I think what I'm hearing here is there's a lot of anecdotes and stories around how, you know, digital health foundationally is about the data. Yeah, we need to sort of make sure we have the right data that's unbiased, that is ethical, and also I think bold public and private sector participation is what is really making all this possible. And ultimately also as we look at also our cloud partners and how they're also rolling out infrastructure and capabilities so that we can respect also things like data privacy and more importantly data sovereignty in Kenya and across the continent. So please give our panel a very big hand for all their contributions. Thank you so much, all of you. And I hope for the audience here, you've also taken away something, and I think some of them may be available for conversations after this session. Thank you so much.